everyone, this is Island Nurse and welcome back to my YouTube channel. Now in this video, we're going to be talking again about stroke or cerebrovascular accident. Now in our first video, we went over the definition, we looked at the causes and types, and we also looked at the clinical manifestations of stroke. And in this video, we're going to be focusing on nursing management for the patient with stroke in the acute phase, and that would be for the first 24 to 48 hours. Now, the National Institute for Neurologic Disorders and Stroke advises that whenever we're assessing or evaluating a patient with stroke, that we need to use some tool. One of the tools that we use is this acronym FAST, and this acronym is really used to teach community members the signs and symptoms of stroke and to help them, to teach them what to do in the event of a stroke. So let's go through our acronym FAST. So the F stands for facial droop. So if you notice a person's face start to droop on one side, you suspect a stroke. The A is for arm weakness. So you might notice that the arm becomes very limp or listless. Again, you suspect stroke. The S is for speech problems. And if you observe that the person's speech is slurred or they're using the inappropriate words to describe objects that they're familiar with, you will suspect a stroke. And if you observe any of these symptoms, the T stands for time to call 911 or whatever is your emergency services number. Now, let's talk about how we diagnose a stroke. So the patient comes into the ER with all of these symptoms. How do we diagnose a stroke? So the gold standard for diagnosing stroke is a non-contrast CT scan. And the CT scan is going to determine whether the patient is having an ischemic stroke or a hemorrhagic stroke. We also have to do our neuro assessment, and this is one of the tools that we use, the NIH stroke scale, and we'll go over that in a bit. So when a patient is diagnosed with stroke, if it's an ischemic stroke, the patient is going to get TPA or tissue plasminogen activator. So TPA, like the name suggests, is a drug that activates plasminogen, and the plasminogen is then converted into plasmin, and plasmin results in fibrinolysis, and this is where the fibrin molecules in the clot are separated, and this causes the clots to dissolve. The thing about TPA though is that it not only works on the plasminogen that is attached to the clots, it also works on plasminogen that's just circulating in the blood. And as a result, one of the major side effects of TPA is bleeding. So that is something we have to look out for in our patients. Other medications that a patient with stroke can get include antiplatelets, which will help to prevent further clot formation. However, antiplatelets are not given until after 24 hours of administration of TPA. The patient, and especially patients who have hemorrhagic strokes, can also be placed on anticonvulsants to control the blood pressure. They can be placed on anticonvulsants to prevent seizures, to control and prevent seizures rather, antihypertensives to control the blood pressure, and osmotic diuretics to facilitate getting rid of the excess fluid from the body through urination. Now, in order for a patient to get TPA, they have to meet certain strict criteria. So let's talk about these criteria now. So we have inclusion criteria and we have some exclusion criteria. So very importantly, TPA must be given within 3 hours of the onset of the symptoms of the stroke. So this is why it is very important as the nurse for you to get the history from the patient, if they're able to, or from the relatives to determine the exact time that the symptoms of stroke started, because we cannot give the patient TPA outside of this 3-hour window. There are a few exceptions when they can get it up to 4.5 hours after, but they have to meet certain strict criteria which will be determined by the physician. But as a general rule, we have to stay within this 3-hour window, because if we give it after that, the patient can have serious bleeding, and we want to prevent that. Okay, also this TPA is for ischemic strokes only for patients who have ischemic stroke, because like we're saying, the TPA, one of the side effects is bleeding, and if a patient is having a hemorrhagic stroke, we don't want to give a medication that can cause bleeding. We have to maintain a blood pressure of 185, 110, so the systolic blood pressure has to be below 185 and the diastolic below 110. The patient cannot have had anticoagulants in the last 48 hours. Okay, so these are what we traditionally call blood thinners. So we have to ensure that the patient has not had anticoagulants in the last 48 hours, or they would not be a candidate for TPA. Also, the patient that has a brain tumor, has an MI, myocardial infarction, or heart attack, or pericarditis would not be a candidate. Also, any patient that has cranial or spinal surgery within the last 48 hours, they cannot have TPA. They are not a candidate for TPA. Some other labs that we have to be mindful of are the platelets and the glucose. So if we do the platelets and it's under 100,000 millimeter cube, the patient is not a candidate for TPA. And also the glucose cannot be below 50, in which case the patient is hypoglycemic, and it cannot be above 400, in which case the patient is hyperglycemic. And that is because the symptoms of hyper and hypoglycemia mimic symptoms of stroke. So if we observe that the glucose is within this range, it could be that the patient is hypo or hyperglycemic, and we don't want to administer medication for one condition when the patient has another condition. So TPA is usually given as an IV. We give 0.9 milligrams per kilogram of the patient's body weight. So the patient's body weight is converted from pounds into kilogram. So 0.9 milligrams per kilogram. And we give 10% of the dosage as a bolus. And then we give the other 90% over 1 hour. So the bolus is given over a 1 minute period, and then we give the other 90% over a 1 hour period, and the patient cannot get more than 90 milligrams of TPA. Now, what are we going to do for the patient who is having TPA? And remember, we're giving TPA to our patients with ischemic strokes. All right, so while the patient is on TPA, we want to monitor their vital signs, very importantly, and the neuro status. And this is what we're using to monitor the neuro status. We're using the NIH stroke scale to monitor the neuro status. So this scale has 11 different segments, and a score of over 22 would mean that the patient is severely impaired. So the areas that we assess on the stroke scale are the level of consciousness. We look at the best gaze, visual perception, extinction and inattention, facial palsy. We look at motor skills of the arm and leg. We assess for limb ataxia. We assess the sensory areas, language, and dysarthria. And we'll go more in depth into the NIH stroke scale in a subsequent video. So we're going to monitor vital signs and neuro every 15 minutes for 1 hour of the infusion. So while the TPA is being infused, we're monitoring the vitals and the neuro every 15 minutes. We also want to have the patient on continuous pulse oximetry, and we want our oxygen saturation rate to be above 92%. This patient for the first 24 to 48 hours would be on bed rest. We also want to have the patient hooked up to a continuous cardiac monitor. So we're doing cardiac monitoring continuously. We also want to have oxygen because we want to pay attention to the ABCs, airway, breathing, circulation. So we want to have oxygen at the bedside so we can administer oxygen as ordered. Okay, very importantly, we have to initiate aspiration precautions. So that means that we're going to keep the patient NPO, nothing by mouth, until a swallow evaluation is done. And this swallow eval is usually done by the speech therapist. And then after the evaluation is done, then we can determine whether the patient can eat or not, or whether the patient has dysphagia. Because remember, with a patient with stroke, they have weak muscles, and so they're not able to chew and use their facial muscles as they normally would. So they're at risk for dysphagia, for aspiration, and that can lead to pneumonia. So very importantly, so we're going to keep the patient NPO until the swallow evaluation is done. We want to have suction at the bedside, right, in case the patient needs suctioning. After the swallow eval, if it is determined that the patient can eat, we want to have the patient, or the patient is most likely going to be placed on a soft diet. They're going to have thickened liquids, and we want to monitor the patient during mealtime. So we want to follow the level of supervision during mealtime. So whether the patient has to have a one-to-one, or whether you have to observe the patient from a distance, whatever the protocol is, we want to ensure that we follow that protocol. Also, we want to encourage the patient to do the chin tuck. So when they eat, we want to encourage them to, after they have chewed the food, we want to encourage them to tuck the chin into the chest. And in that way, we're ensuring that the food goes into the esophagus and not in the trachea. Because we know that if food goes into the trachea, then the patient can have aspiration, and that can lead to aspiration pneumonia, and we want to avoid those complications in our patient. We also want to elevate the bed head, so like a semi-Fowler's position from 30 to 45 degrees. We want to do that. We want to pay special attention to oral care, and this is very important because sometimes patients with stroke, when they eat, they do what is called pocketing. That is where they ingest the food, but they would have the food like in the corner of their mouth, and they would keep the food there for hours. And again, if they do that, that can lead to aspiration, and we want to avoid that. So we want to give good oral care. We want to monitor their lung sounds. So we want to, in addition to doing regular vitals, we want to listen to lung sounds. All right, we want to pay close attention and ensure that we don't do anything to increase their intracranial pressure. And this is especially so for the patient that has a hemorrhagic stroke. So if the intracranial pressure is increased, these are the signs that these are the changes that you would see in the vital signs. You would see an increase in blood pressure, so hypertension. You would see a decrease in the heart rate, bradycardia, and you would also see a decrease in the respiratory rate. So we want to pay close attention to those vitals. So what are we going to do to ensure that we don't increase intracranial pressure in the patient? Again, just like for our aspiration precautions, we want to keep the bed head elevated in a semi-Fowler's position. We want to encourage slow movements. Okay, so if we have to turn the patient in bed, we want to ensure that we do it slowly. We want to decrease head flexion as much as possible. We also want to discourage sudden movements because we know sudden movements can increase the intracranial pressure. We want to ensure that we keep the patient in a dark and quiet environment. Too much light or noise, these are things that can increase intracranial pressure. We also want to initiate seizure precautions, and because an increase in the intracranial pressure can lead to seizures. We want to also prevent the patient from being too hot or too cold. So we want to maintain just the correct temperature in the room. So we don't want to cause the patient to become too cold. So if the room, we know sometimes in the rooms we have the air conditions and they're very cold, we want to ensure that the patient has a blanket. If the patient complains of feeling too hot, we want to remove layers of clothing, okay? Because again, extremes in temperature can cause an increase in the intracranial pressure. We also want to be monitoring the patient's glucose level, right? To prevent hyper or hypoglycemia. Let's talk a little bit now about intracranial hemorrhaging. Remember, we said that bleeding is one of the major side effects of TPA, and this can lead to intracranial hemorrhaging. So what are you going to notice when a patient has intracranial hemorrhaging, or what are the symptoms that you would see that would cause you to suspect that the patient is having a hemorrhage in their brain? Okay, so if the patient complains of a sudden severe headache, if you notice that the patient suddenly becomes lethargic, very lethargic and listless, you notice an acute raise in the blood pressure. So let's say you've been maintaining the blood pressure below 185, 110, and all of a sudden you notice the blood pressure go to 250 over 150, that would be cause for concern. And if you notice a deterioration in the neurological status, so you would have been doing the neuro exams all the time, and if you notice a deterioration, all of these symptoms put together would suggest that the patient is having an intracranial hemorrhage. What do you do in a case like that? You want to immediately stop the TPA and get an order from the physician for a repeat CT scan so we can see what's going on in the brain. We can see if the patient is having a hemorrhage. We want to avoid IM injections as much as possible. Remember, again, this patient is at risk for bleeding. So if you can avoid IM injections, especially in the first 24 to 48 hours, you want to do that. You also want to observe the patient for an anaphylaxis, right? The patient can have an anaphylactic reaction to the TPA. So if you notice the patient starts itching or they're having hives, you observe angioedema. The patient may have swelling of the tongue, the lips, and the face. Those will be signs of an anaphylactic reaction. And again, if you observe that, you want to go ahead and stop the TPA right away. So there you have it. We have spoken about the nursing management for patients with stroke. And if you found this video informative, don't forget to like and subscribe, and feel free to leave your comments in the comment section down below. Thank you for watching, and see you next time.